Hello and good morning. My name is Gideon Hirschfield and welcome to this Medscape live social event entitled What Do New Therapies for Primary Biliary Cholangitis Mean for Practice? I'm a hepatologist based in Toronto and I'm joined by two faculty members today who are going to try and give you the next 30 minutes focus on PBC, what's new and exciting, and give their perspectives. Professor Steve Flamm from the Department of Internal Medicine and Department of Hepatology, Rush University in Chicago, and Professor Sonal Kumar from Weill Cornell Medical College in New York. Hello, guys.
Hello.
Hello.
So I'm going to be talking a little bit about PBC, and I'll introduce some of the themes and some concepts, and you can follow along with some slides that you'll be able to see on whichever platform that you're watching. I guess what really interests all of us, and the reason we're here, is that we think there's a new paradigm in PBC evaluation and goals of treatment. We believe that there's a lot of excitement for our patients. We currently have really essentially a wait to fail approach to treating PBC. Diagnosis, assess response, second line therapy, and manage symptoms. But our new paradigm is more around personalized care, targeting therapies to a patient profile, treat based on individual baseline risk and treatment response, and ready to be aspirational. So before I delve into a little bit more detail, maybe I'll just ask Steve whether he agrees with my enthusiasm for PBC in the future.
Thank you, Gideon. I absolutely do agree with it. You know, PBC is one of those diseases that we've always thought is uncommon, but I think many key opinion leaders agree that it's increasing in incidence and prevalence around the world. So this is a problem that providers that take care of patients with liver diseases actually will see. And we've kind of used this approach in the past where we treat patients with ursodeoxycholic acid and we kind of watch them semi-aggressively, not knowing really what to follow too well, and hope for the best. But we've gotten a lot of information recently, and we have new products, we're going to discuss them shortly, that I think have allowed us to know when to be very aggressive with certain kinds of patients. So yes, I too, like you, Gideon, am very excited about this new approach.
And then what about you, Dr. Kumar? In Manhattan, are your patients happy to have a passive approach, or are they now wanting a more proactive approach?
I think one of the nice things about PBC patients in general is that they're very well informed and very, an active participant in their care. So I think they don't like this, one size fits all algorithm that we've previously used in the past. And they're really receptive to this personalized care and really risk assessing our patients and adjusting our treatment goals and management algorithms based on who they are individually. So it's been very well received.
And that will allow us to move into the first topic for discussion, which really is, the goals of treatment. So, what I want to do is just show some data and then listen to your thoughts about, should our care be intuitively about normalization of ALT phos and bilirubin? Is that really what we should be offering our patients? Because, that really, I think, is where it's headed. And we do have data from Global PBC Study Group, which I can show you on the slide, which is really suggesting and confirming that we know the lower the better is the strategy that's associated with the best outcomes. And the patients with the most normal ALT phos are the patients in these big cohort studies that do the best. And indeed, the patients with the best bilirubin are the patients that do the best. And attaining bilirubin levels less than 0.6 times the upper limit of normal and a normal ALT phos is associated with the lowest risk of liver transplant or death in patients with PBC. We also know, of course, that we can stratify, and a lot of us are using, and I think you are as well as expert providers, FibroScan, and we can use FibroScan to sort of get some extra risk stratification. I don't think that's the be all and end all, but clearly we can see that there are subgroups of patients who benefit the most and other groups where we have to really personalize and think about whether they do need therapy beyond UDCA and into all these new exciting second line therapies. So I don't know if I go back maybe first to Dr. Kumar, does this data convince you that you can tell your patients that intuition is right in managing PBC?
Absolutely. I think it's been a little bit tricky with PBC because there have been different criteria of what our goals of treatment should be in the past. And now, but though in the back of our minds, we've always known that the lower is better, and normalization of alkaline phosphatase and bilirubin should be our treatment goals. And now that we have this data, over the last few years, it's really, really convincing and reassures us that in fact should be our treatment goal. Even, a slight alkaline phosphatase level above normal confers an increased risk for our patients. So we really should be striving to achieve that normalization.
And Professor Flamm, I mean, you're one of the leaders to have essentially helped cure hepatitis C. And, you went through the era of hepatology where our aspirations just really got better and better. Do you think I can say the same now about PBC? Maybe not cure, but I can be as aspiration about control?
I really do, Dr. Hirschfield. This is one of the moving goalposts. It's funny, Dr. Kumar just said we've always known lower alkaline phosphatase is better. It goes to show you how old I am, because we didn't actually always know this. When I trained, and even for the first 10 years when I was an attending, we actually didn't know that. I remember asking my mentor, once we started ursodeoxycholic acid in a PBC patient, how do we actually know if it's working? Do we use the alkaline phosphatase? And he said to me correctly at the time, we actually have no idea. You just start the medicine and you hope for the best. And then it became clear in the last 10, 12 years that the lower the alkaline phosphatase, the better the patients do. And so it's been a little bit of a moving goalpost, I'd say, in recent years. But I think this is the right approach. We need to be more aggressive, and we need to really try to normalize that alkaline phosphatase. And I think guidelines will catch up with the recommendations that I think, or the treatment approaches that we follow, with really trying to aggressively lower alkaline phosphatase in patients, because in the end, I think that's going to optimize outcomes.
I hope so, because I also hope that people recognize that people are living longer and longer, and, many of our patients are going to live to 85 or 90 with this disease. And many of them are going to want to have the treatment targeted to that kind of life expectancy, and not to be told that, it's okay to plod on with abnormal tests. And that really comes into the next panel discussion point about which patients should be considered for second line therapy. Because I think that's really, about individualized care. And we're good at the ongoing treatment assessment in patients with PBC. And I can show you that this kind of paradigm in a slide of where we're understanding about risk. Okay. And really, I think what we're talking about is, treat risk, not stage. Everyone's so obsessed about stage in PBC, but actually it's risk. Low risk, intermediate to high risk, and the patients who really need to be saved with liver transplantation. And so, maybe Professor Flamm, how are you sort of thinking about the thresholds for second line therapy? Where are you looking at, what ALP-FOS cutoff, and when are you looking to think about that decision making?
That's a great question too, Dr. Hirschfield. I don't think we have everything outlined yet on this individualized approach and what actually constitutes risk. Because of course, like with any disease, some people have a disease and they don't do poorly. So I have patients that don't take ursodeoxycholic acid or anything else, and they do fine over the years with PBC. And then other ones are at high risk and seem to have a much more rapid progression. So we need to really identify those types of factors, because I think those inform us as to who we really need to be aggressive with some of these second line therapies. As far as what's the threshold for alkaline phosphatase, one of the first studies that came out from the global PBC study group showed that people with an alkaline phosphatase greater than 1.67 times the upper limit of normal range on therapy did worse. So we and FDA, for regulatory purposes, they've used that threshold to determine when a patient should be on second line therapy. And I think we're evolving to even maybe assess higher risk patients with even lower alkaline phosphatases if they're still elevated. I look at the racial group and ethnicity. Patients, for some reason, at least in my practice, and there are some literature to support, patients, African American, Hispanic, they seem to do worse. They have sometimes a more aggressive natural history. Younger patients who get diagnosed, I'm more aggressive. Patients with much higher alkaline phosphatases, I'm much more aggressive. And patients that have more fibrosis, when I do assess the histologic stage of disease, I'm more aggressive. So as far as outcomes go, those are some of the factors that I entertain when I see a patient with PBC. And then maybe Dr. Kumar will comment, or you. Symptoms also matter too, because some of these newer therapies actually help the symptoms of PBC too for the first time. So that might be another reason to be aggressive with second-line therapy.
I agree. So I was going to ask you, Dr. Kumar, I mean, what I do is look at age, I look at bloods, I look at FibroScan, and I look at symptoms. Is that kind of, your approach when your patients are coming to clinic?
Absolutely. I use the exact same thing. I mean, I completely agree with Dr. Flamm. There are certain phenotypes or characteristics for patients that affect their disease progression. And I think we're still looking at that and identifying those factors. But at baseline, for every patient right now, with what we have available, I pay attention to the factors such as age, fibrosis, degree of elevation in their labs, and symptoms.
And are you waiting 12 months to make that decision, or are there some patients where you might feel that they should be moving a little bit quicker, particularly with your access to these new therapies?
Yeah, I think, if you look at the old guidelines from the AASLD, the recommendation is to wait the 12 months. But we really know who is going to respond to first-line therapy pretty quickly. And I start making that decision on second-line therapy much earlier than 12 months. And I really shoot for the 6-month mark. And, now we have data to support that decision-making process too, to assess these patients at 6 months. You can predict the majority of patients that are going to be responders versus non-responders. So I've been doing it at 6 months. I don't know, Dr. Flamm, have you done the same, or?
Absolutely. I'm thoroughly convinced that ursodeoxycholic acid and the second-line therapies actually respond quickly, if they're going to respond within 3 to 6 months. I tell patients ursodeoxycholic acid is not a medicine that kicks in. It doesn't not work for a while and then all of a sudden work. The only time that happens is if a patient wasn't taking it at the beginning and then starts to take it, because it doesn't kick in. You can tell, in my opinion, in 6 months if this is working or not, and how well, and then make your decision on second-line therapy. Dr. Hirschfield, what do you do?
No, I agree, and I think I individualize it to the patient. I am, thinking about their symptoms and pruritus, and with these new agents and some of the agents having really quite clear data on pruritus, I think that comes into my decision making. But totally, I think the 12-month point was really is a historical thing about where the data was, not again intuitive care. And so I think you're going to individualize it. I don't rush everybody. I think some patients want to get used to the diagnosis, and you've got to get to know them. You're living with this disease for decades and decades. And so, you want people to be adherent to the therapies and to understand it. But why don't I now then just go through, I've got a few slides on second-line therapy options in PBC, and I just want to present those. And then I really want to hear from the two of you about, in particular, the place of the new therapies, because, there are now, second-line therapies which are approved and off-label treatments, and particularly in the US, you've got obeticholic acid, which continues to have an FDA approval. You've got 2 PPAR agonists, both approved in 2024, elafibranor, an alpha delta agonist, seladelpar, a pure delta agonist. And then, probably not so relevant to the US, but more relevant to the rest of the world, there is data on, the fibrates, which is actually why we've landed up with elafibranor and seladelpar, because of what we learned. Okay. No one's going to say it's easy to prove benefit in this disease. And I think obeticholic acid demonstrates the challenges of bringing a new therapy to a rare disease and trying to demonstrate that obeticholic acid does more than just biochemical changes. And there is data around the long-term effect and liver event-free survival for obeticholic acid. And the way we tackled that, really, if you think about the history of trying to prove URSO works, I mean, that took 30 years, okay? And with OCA, we've started to see some real world data where we compare patients who've got OCA versus external controls, and we can demonstrate that the patients receiving OCA are doing better than the external controls, be that from the UK PBC cohort or from global PBC, okay? And this is at least supportive along with other real world data. There was just a paper published using the Komodo database demonstrating similar evidence for OCA having an impact on survival, so moving beyond biochemistry. And I think we're going to be looking for this for all of the drugs, okay? But then really, you know, there's two pivotal studies that need to be discussed as we listen to your thoughts about the new PPAR agonist. There's the first study, the response study for seladelpar. So we had URSO, we have given in gram quantities. We have obeticholic acid, 5 to 10 milligrams. You know, we know the challenges of obeticholic acid. You can't use it in advanced liver disease, and there's clearly a pruritus concern. Seladelpar, you know, with a very similar clinical trial design to obeticholic acid, has 6 out of 10 patients meeting this regulatory definition of a biochemical response. And although not shown on this slide, 25% of patients normalized their ALP FOS, and pruritus was significantly improved in a key secondary endpoint. So this is the seladelpar molecule, 10 milligrams a day, PPAR delta. You know, the other trial, ELATIVE, was a trial of elafibranor dosed at 80 milligrams, an alpha delta agonist, where 51% of the patients are meeting, again, this regulatory endpoint of composite change in biochemistry. It's about, I think, 14 to 15% of patients normalize ALP FOS. Their key secondary endpoint of pruritus was not met in their clinical trial. So this led to the approval of these two drugs. And really, I suppose I'm now going to go back to you. You're practicing, you're in the thick of it, both of you. Where should PPAR agonists be positioned in PBC treatment? This is these are the new kids on the block, you know. So maybe Professor Kumar.
Yes, I mean, it's been a really exciting time for PBC to have these new medications after a long time to offer to our patients. And I think it's really shifted the dialogue. You know, I've had some good experience with obeticholic acid, but like you mentioned, the pruritus issue, that it can sometimes cause pruritus, it's a discussion that you have to have with patients. And it was a difficult discussion to have in a disease that already is associated with pruritus, to then potentially start a medication that could worsen that or cause that. Patients weren't very excited about it. And now it's a complete shift in what we're talking to our patients. Now we have medications that not only work and have, you know, great efficacy, but also can potentially improve patients' symptoms. And now I think we're starting to acknowledge a lot more about and recognize more about patient symptoms. And now we have something that can treat both the liver disease and the pruritus. It's nice.
So what about in Chicago? What's your approach now, being in 2025 as we start the year, and you've got these agents accessible for your patients?
Yeah, this again, Dr. Hirschfield, is a very exciting time because of the appearance of these agents on the market now for treatment of these patients for second-line therapy. I too used obeticholic acid many times in patients, and aside from pruritus on relatively rare occasion, I really didn't have any issues with it. It worked as I would have expected from the pivotal trial that led to its approval in 2016 in the United States. But these PPAR agonists, I think, are very, very exciting. First of all, their efficacy is also excellent. And secondly, they do have this beneficial effect on pruritus, which Dr. Kumar mentioned. And even though elafibranor didn't achieve statistical significance with pruritus, there was a strong trend to improvement in pruritus. And I must tell you, in patients that I've used it in real life so far, in the first month since approval, I have seen benefit in pruritus with both drugs, actually, elafibranor and seladelpar. So this is very exciting. And I think, of course, they're going to play a prominent role now in the management of patients for second-line therapy with PBC. How about in Toronto?
Well, we're still waiting. You know, we're always a tiny bit behind you, and there's usually there's probably going to be an issue around tariffs as well for these drugs. But you know, we're big believers in this approach to treating patients. We're big believers in PPAR agonists. We're believers in combining them. Actually, we think there's going to be some patients who, you know, will get the PPAR agonist. You'll see this improvement in their blood tests and their pruritus. But that's not going to be enough. And you know, for those younger patients, we really do believe that we still need to have access to, you know, a obeticholic acid, because I think that's where we're headed. I mean, let me just delve a little bit into symptoms, because I think it's really important for patients and the impact of symptoms on pruritus from these three different drugs. You know, and I think, you know, obeticholic acid is very interesting because we know it makes you pruritic, and actually the way it works to make you pruritic in a proportion of patients is because in the IL-31 gene in the hepatocyte, there's actually an FXR binding domain, and when FXR comes in, it doesn't matter what kind of FXR agonist, IL-31 goes up. Okay, that's really interesting because, you know, the PPARs, you know, are antipruritic. Bezafibrate's antipruritic. Seladelpar met its key secondary endpoint. In those with patients with moderate to severe pruritus, there was statistically significant improvement in pruritus, and in fact, the pruritus effect was seen in the whole population. As you say, for elafibranor, you know, the key secondary endpoint was not met, but there were other analyses of PBC-40 and 5D itch where there was, you know, pruritus improvements. What's really interesting for seladelpar, there's data that IL-31 goes down in association with the improvement in pruritus. Okay, so I think that's a really important point. We still need to improve things like fatigue. Okay, I just also want to cover safety, and then I want to sort of listen to you again, just synthesize for the clinicians on this morning's social event. You know, safety, we've talked about obeticholic acid. We understand the concerns of the FDA. We understand the concerns around pruritus, and we understand the black box, and our providers know not to use OCA in decompensated cirrhosis, prior decompensation, or patients with portal hypertension. Elafibranor and seladelpar, you know, have quite good safety profiles. We need to learn in clinical practice. You know, elafibranor reports weight gain and some other non-specific symptoms. Similarly, seladelpar had some headache and some non-specific symptoms. Okay, so does that reassure you as you apply these new therapies, Professor Kumar, that you know how to use them for the patient in front of you, and you also how to educate to the providers in your network of care?
Yes, absolutely. I mean, I think, you know, obeticholic acid is, you know, with its unique mechanism of action compared to the PPARs, it's sort of off by itself. And then, you know, using that in patients who are probably on it already. But now we've shifted towards the PPARs, which, you know, especially in patients who are symptomatic. And like Dr. Flamm said, I've used both of them, and I've seen improvement in pruritus in both of the patients, and in both groups of patients. And I haven't really seen much side effects on either end with either of the PPARs in terms of tolerability. It seemed to be they seem to be very well tolerated. And so although both have side effects that are listed, I try to, you know, reassure my patients that overall, so far, our experience with it has been pretty well. Yeah. It's been.
And you, Professor Flamm, any concerns when you're thinking about other coexistent drugs that patients are on? I mean, I think that's again something we all just need to get used to. I mean, we know that there's a history of concern around rhabdomyolysis and a concern around interactions with statins. There was some CK changes in the elafibranor study that they weren't reported in the seladelpar study, but again, this is early phase 3 data. Is that influencing just how you're just making sure when you see these patients before you start the second line therapies, you're looking at their drug history to be on top of that?
Of course, Dr. Hirschfield, you know, with any of the drugs, you know, I only work in the liver space. I don't know about other areas, but in the liver space, it seems almost all drugs that we use for any of the diseases have drug-drug interactions that providers have to be careful about. And it's true here too. And there are always extenuating circumstances that might push you towards one product versus another. Elafibranor is a teratogen. It can cause birth defects in vitro. So in a woman of childbearing age, you have to be very careful about that in your counseling. It also has a potential interaction with hormone-based oral contraceptives, so you have to be careful with that too, particularly in a setting where there's teratogenicity, meaning can cause birth defects. So yes, you always have to look at drugs and other aspects of the patient when you're going to be using a drug. One thing too, I'm not sure you mentioned, obeticholic acid, you're not supposed to use in people with portal hypertension or decompensated disease. Elafibranor and seladelpar, not so much the portal hypertension, but they're also not to be used in people with decompensated liver disease, meaning people that have had complications from cirrhosis. So
Agreed.
There is a little bit of a similarity there.
You got to know when you're not, when transplant's the best treatment for your patient, and a Child-Pugh BC patient, is not the patient who's going to benefit from these new drugs. And just for the last couple of minutes, I just want to talk about other promising new therapies on the horizon. I want to ask you, both of you, perhaps to, whether you're in touch with your pediatric hepatologist. Now, pediatric hepatologists have access now to IBAT inhibitors for Alagille's and for PFIC syndrome for treating pruritus. And, there are efforts to develop IBAT inhibitors for adult patients with PBC. I'm just interested to know, whether you still see a role and an opportunity for new therapies which are really just about the symptom of pruritus. Dr. Kumar?
Yes, absolutely. I'm not as close with the pediatric colleagues, but I still think there's a role for patients with cholestatic itch. I mean, the itch that patients describe can be really horrible and can affect their day-to-day, and their alkaline phosphatase can be normal. And so you could potentially have adequate control for patients and from a liver standpoint, from a biochemical standpoint, with just first-line therapy, but their symptoms aren't controlled. So I think there's always going to be a role for something like the IBAT inhibitors for patients with severe symptoms.
And Professor Flamm, have you been in, there's been data presented for linarixabat in phase 2. There's another trial where there's been some pilot data. Professor Cowdy presented some data for a different IBAT inhibitor from Mirum Pharmaceuticals in phase 2 in PBC. Can you see why that would be beneficial if we can get those drugs across the line?
Yeah, of course. I mean, they're more, at least the data I've seen, more for the pruritus aspect only rather than the disease process. And just IBAT inhibitor, for anyone that doesn't know, is an ileal bile acid transporter inhibitor. That's what IBAT stands for. And it turns out that in diseases like PBC and other of the pediatric diseases, which are not PBC, but have some similarities, the itching component is remarkably improved. And thus, yes, for people that have severe itching with PBC, these kinds of products are very, very exciting. They've already been shown to be safe enough to be approved in kids, I believe. So therefore, on the safety aspect, we would expect and hope that they would be tolerated by adults. But I think they're very exciting as a complement to our treatment strategy for patients that are troubled by severe pruritus. We don't have good fatigue, interventions yet for PBC. But one of the reasons PBC patients get fatigue is because the itching that they have is very bad at night and they can't sleep, and it makes the fatigue much, much worse. So it is quite possible that these itching products will actually help their sleep, which will help their fatigue too.
Yeah, I think that's really important. I think we've actually done a pretty good job of filling nearly 30 minutes. We're into the last 60 seconds. So I just want to round up a little bit to say, number one, it's exciting times for patients with PBC. Number two, don't wait to fail. Wait to charge for success. Number three, there's a lot of choice there. You've got urso, which is a bile acid pool modifier. We're not saying don't use it, but you've got other second-line agents. Obeticholic acid with a track record of 6 years. We know who to use it in and who not to use it in. And there's now these two new PPARs, which, are being dosed at, low doses and having efficacy biochemically. And efficacy is evident from the clinical trials around itch. And it comes down to bile acids, autoimmune disease, but the bile acids and reducing bile acid toxicity. And then there should be more in the future. We hope, we don't know, we hope there'll be more in the future, because again, bile acids are important for pruritus. And if you feed the hepatocyte less bile acids by interrupting enterohepatic circulation, it turns out that's also antipruritic. So to end, I want you to claim your free credit by scanning. And also, I want to just generally thank you for participating in this activity. Thank you, Professor Flamm. Thank you, Professor Kumar. That was a lot of fun, as I thought it would be.
Thank you so much for having us.
Bye-bye.
Bye-bye.
Bye.